becomes a router.
This would be all. Are we on live? Or no?
Yes, sir. We're live now.
Okay. Hi, good evening. Welcome from West Bengal Arthroplasty Society and WBOA. This is the third combine that we are doing, and in this very trying times, we are going to beat Corona. While we go ahead trying to beat Corona, let's do it from our home. So every month we'll have something exciting to look forward to. So today the exciting debate, and we hope Indrajit will really liven it up, poking panelists from both sides. It's a debate on whether CAS, robotics are the only way forward in arthroplasty or are there other ways. So at the end, we will end up with Dr. T Mohan from Kochi, Amrita Institute of Medical Sciences, who will be sharing his experience with MACO. I think this is the first one in the country, and they have done the largest series. Among our panelists for our debate, we have Dr. Santosh Kumar. He has been doing, I think, one of the largest numbers of computer as surgery, Santosh. Next is going to be Dr. B D Chatterjee is coming online now, who's going to be telling us, are there other ways other than CAS? Next is going to be Rakesh Rajput, who's been pushing for robotics for a long time now and has been doing it. And then Vikash telling us whether or not that's the only way forward, whether there are other ways out. And Indrajit is going to be moderating this whole lively session. And please feel free to ask questions on the online platform, and we'll forward it to Indrajit. And we will thank Blissum Pharmaceuticals, who's helped us. So with this, I hand it over to Dr. Indrajit Sardar to start off the procedures. Sardar.
Well, welcome to everybody. We're having incisive debates all over the country on many things, but this one will perhaps be the most enjoyable, but no less controversial. So we have extremely good panel of lecturers who will be debating on various aspects of it, and hammer and tongs. I don't think any quarters will be asked for or be given. And that's the way we want it. We want questions from everybody, and we want the debate to reach a definitive sort of conclusion right at the end, because that's the time when we resume our normal selves and become very friendly with each other, and we use the cups of coffee and tea. So let's start off first. I think we start off with Santosh.
Hello, sir.
So, Santosh, are you ready to talk on your support of robotics?
Yeah. Yes, sir. Yes, sir.
Yes, there it is, Santosh. So that's good to see you. You're looking good and healthy, and that's, I presume that's the way you are. So let's start off the proceedings with you talking on the robotics aspect of it. It's basically a debate on one side robotics and the other side the others. And of course, we have no less a person than Mohan Thadiya. It's great to see him, and we welcome you to the West Bengal Arthroplasty Society debate. And I'm sure he'll be enlightening us with his experiences, which is one of the highest in India.
Yeah, Indrajit, hello everybody.
Yes.
Hello.
Hi,
yeah.
Hi, BD.
Yeah, hi. I was told the first part will be on navigation. That's what Rajiv told me.
Yeah, navigation.
He's talking CAS.
Yeah.
Yeah, I think the robotics comes in the second half of the debate, is it?
Yeah. So
okay.
It's actually one side on navigation and robotics, and the others on the others, which you are one of the debaters.
Yeah. Yeah. Okay.
So good about it. Anyway, so let's start off with Santosh. Santosh, you're on.
Thank you, sir.
Share your screen.
Actually, it's writing host disabled participant screen sharing.
Or no? I think he's not getting screen sharing.
You can do it. Please try again.
There you are.
Okay, so thank you, sir. Today I'm going to talk about the role of computer-assisted surgery, that is navigation in joint replacement, especially knee arthroplasty. So whatever technique we use, the general principles of TKR will be to restore limb alignment, achieve soft tissue balance, use correct implant, restore limb length, restore the joint line, and obtain a good range of movement. So that's the general principles of TKR, whatever technique we use. And we have been doing a continuous search for precision. So it starts with more and more precise instruments, specific instruments, navigation and robotics. All these are a continuous endeavor to search for a better precision in as far as knee arthroplasty is concerned. So we are very used to navigation. It's an everyday tool in our cars, and we are very used to navigation. And the goal of navigation is to achieve high surgical accuracy and precision, because the results of knee arthroplasty are dependent on the precision and accuracy. It's all mechanics, it's all physics that is involved in it. So we need to achieve this high surgical accuracy and precision. So what are the components of navigation? Basically, the navigation that we do is a kinematic navigation, in which there is an infrared emitter, which are tracker bulbs. It can be active or passive. There are rigid bodies, which will show subsequently what is these rigid bodies. They are pins which are put on the bones, and the anatomical structures, which are also rigid bodies. We have a 3D camera, a computer, and a screen. So basically, this is a kinematic navigation wherein we don't require any preoperative CT scan or a preoperative MRI. We need intraoperative data collection, and it's a kinematic calculation. And whatever we are calculating is based on the relative movement between the rigid bodies and the concerned elements. So just a small brief for the OR setup of this. I will go through it very fast. This is our OR setup. So this is the optical trackers, and this is the optical trackers which emit infrared rays, and this is we are putting the rigid bodies. In this kinematic navigation setup, we put two rigid bodies, one in the femur and one in the tibia. So in this setup, we go with a single pin navigation. There are several setups which use double pin navigation, double pin rigid bodies. With a single pin rigid body above the joint line. They are put a fixed distance above the joint line, and all subsequent measurements will be relative to this pins, these rigid bodies. So we put the tibial rigid body. These are all single pin rigid bodies. Then we take the kinematic. We take the anatomical landmarks. We take the anatomic as well as the kinematic center of rotation of the joints. So we do the desired cuts, and then we do the trial implants, and finally we achieve a limb length alignment, 0 degrees of flexion extension and 0 degrees of varus valgus. So these are the rigid bodies which are put, and there is a femoral and a tibial rigid body. And then we do a kinematic alignment. We show the important landmarks to the computer. This is how the cuts are done, and then they are subsequently measured. Now, this navigation system allows for both systems. One is this measured resection technique, and another one is this gap management system. In gap management system, we start with tibial cut first, and we do a preemptive planning. We do a preemptive planning in which we decide the rotation of femoral component, the sizing of femoral component, and the placement of femoral component. We also decide on the ligament balancing that is required or not required. Based on this preemptive planning, we execute the whole thing. Based on this preemptive planning, we execute the whole thing. So the femur is cut, and the verification of result, the implants are placed, and the verification of results are done subsequently in varus valgus and flexion extension, sizing and all, everything is done. So the query that after a lot of us have actually done navigation. In fact, all the panelists sitting over here have done navigation. So the query is that whether it is improvement or chaos. That's the query that many people think. To start with, many people do feel that it's a chaos. It's something which is increasing the OT time. It is something which is making things messy. But with time, with subsequent practice, we learn that computer is always right. Computer is always right, and the results are affirmative. There is much less limb alignment outliers in inexperienced as well as expert hand. Both the outliers are very less. What it means is the component placement in varus, valgus is very less. There is less of flexion extension deformity, residual flexion extension deformity. The sizing is far more accurate. Rotations are accurate, and it allows you to test both ways, both in measured resection as well as gap management technique. Medullary canal is intact. Ligament balancing is done. There is improvement of deformities, and it is helpful in very severe deformities. So especially if there is severe deformity like severe valgus and all, it's really useful too. And the alignment is definitely improved. Soft tissue dissection is less because the bone cuts are very precise, and the most important part of this tissue balancing is the bone cuts. So with this, the soft tissue dissection is lessened. Range of movement is better and faster. Fat embolism is less, especially if you are doing bilateral single sitting. Fat embolism chances are less because we are not entering the medullary canal. Post-operative recovery is faster, and blood loss may or may not be more, and operative time subsequently decreases with more and more surgeries. So importance of alignment can never be underestimated. We have in our practice seen that varus placement of tibial components is one of the biggest factors leading to aseptic loosening, and 50% of early revision of total knee arthroplasty were due to instability, malalignment, malposition, and failure of fixation. So this computer navigation system definitely improves the better placement of it improves the placement of the implant components. Now the question is that whether it improves overall survivorship or not. That's what is debatable. But as far as the better placement of the implant components, better varus and valgus placement, better limb length alignment with navigation cannot be underestimated, undermined. The importance of correct size and position of the implants, it cannot be undermined. Femoral misalignment, sagittal overstuffing and malpositioning, axial malrotation, and inappropriate constraint or ligament balancing, and inappropriate joint limb elevation, all these things can be avoided with navigation or robotic surgery. And the impact of navigation indicates there is significant improvement in component orientation, mechanical axis when CAS is used. Surgeon's expectation is there should be no chaos, there should be less trouble. It should not add to the cost or the OR time. Of course, there is a learning curve, and the whole team should work smoothly. That's an expected thing. But benefit of navigation, there is significantly better survival rates. There is 100% reproducibility. What I mean is that it's not left to your eyes whether the flexion deformity is corrected or not, or whether there is a hyperextension. Whatever it is, it's quantitative. It's not qualitative. Whenever we are doing by other systems, it's more of a qualitative analysis that we feel that the deformities are corrected. But it's more of quantitative here. Proven accuracy, better joint line reconstruction, better functional outcome, superior balance knees, less blood loss, less fat embolism, quicker rehabilitation, and shorter hospital stay. These are the definite benefits of navigation. Thank you.
Well, thank you, Santosh. That was very precise. First, I think we will panelists, if they have any questions here. And after that, I'll try and get it anywhere, whatever it is.
I have one question for Santosh.
Yeah.
Santosh, you need to correct that slide of yours where you were comparing directly with navigation versus conventional. There you actually said blood loss more, and later on you corrected when you said benefits of navigation and blood loss is less. So I think that was a bit of error in the slide.
No,
but
that was my mistake. That was my mistake.
no,
Blood
that's
loss
okay.
is definitely
Just
less.
correct it because that will send a bad signal to your opponents.
Yeah. Blood loss is definitely less. One of the major reasons being that the medullary canal is not opened.
Right.
Opening the medullary canal
True.
leads to significant blood loss.
And I think it becomes even more important if you're doing bilateral.
Yeah. Medullary canal is not open, so blood loss is less, and soft tissue dissection, I believe, is lesser as compared to a non-navigated system. So both ways, blood loss is less in navigation.
So do we debate now or do we debate after the second talk?
No, because
No, I think we can carry on with the talks and then probably sit and really dissect out each other's if you don't agree with anything. What do you feel?
Yeah, because
Rajiv?
I have several points, but now if we get into that, then it's going to take a lot of time.
Yeah, it may take up because some of them may be answered by some of the speakers. So I think
Let's roll on the talks and
well, Indra can decide whichever way he wants to go.
Yeah, okay. We can go on to the all the things, provided you remember what.
Maybe one question for each
are-
speaker in the
yeah.
beginning, and then we can move on. Yeah.
No, I have noted down around
Just one
15.
question, yeah, and then
Around-
you can ask later on afterwards.
Yeah, so I have about 15 questions.
I think we'll have to.
I think he's come with questions beforehand rather than listening to the talk.
No. They're all picked from the talk. They're all picked from the talk.
Okay.
I have noted down. So I don't know whether we should get into that now or maybe finish the talks. And
I think I'll get my notebook out because BD is a nice speaker.
I mean, I've got this point by point in my diary here.
Okay, BD, we'll wait for that because if you do that, I think everyone else is going to get bored because
exactly.
So that's
It
right.
may not be boring, but it is going to be time taking.
Yeah, it will be time taking also.
Yeah.
So let's go on to the second speaker. Second speaker, of course, BD himself, right?
Yes.
Yeah.
So now you can share your screen.
Okay. Yeah. So okay. So there it is. I think I'm showing the last slide first. So. Okay, can you see my screen?
Yes.
And
BD visible.
Yeah, and I'm clearly audible.
Yes.
Okay.
You can come a little closer to the mic and speak a little louder. But that's
Is it? Hello. Yeah.
Yeah. That's fine. Go ahead.
Okay. So, well, good evening, everybody. And I think the best part of these meetings is that we get to see each other, even in difficult times such as this. And it's always a real pleasure to meet up with old friends. So, it's a very, I would say it's a quirk of fate that I'm having to speak against navigation when I was one of the greatest protagonists of navigation, maybe even a couple of years back. And I was one of the earliest people to start navigation in this part of the country, and I still navigate. But what has happened, and which is why I think this debate is relevant, is that the indications have become clearer. We now know exactly where this is a distinct advantage, and we also know where this is it's just an additive procedure which really doesn't need to be done, but we still do it from force of habit and because we are used to a certain thing. The enthusiasm overall for navigation has diminished, and we shall see why this is so. So if you ask yourself the question that why do computer navigation surgery at all, the only thing that the computer gives us is coronal alignment. It does not give us rotational alignment. It does not benefit significantly in soft tissue balancing. All it does is it gives consistency in axial alignment. If you are a believer in the doctrine of mechanical alignment propounded by John Insull in his famous paper. Now, what I have done is that I have looked at some of the papers, the landmark papers, I would say, which influenced orthopedic or arthroplasty thought when they actually were published. And these are all in favor of navigation. So I've selected those papers with an idea that we'll try to read between the lines and see what they actually say. Now, this is a paper from Singapore where 108 consecutive patients were randomized, undergo computer assisted and conventional. So it was a comparison between the two, and they used long leg radiographs for functional assessment, and I've evaluated it 1 year. So computer assisted patients had longer operating time. No matter what anybody says, it takes a little bit longer. There was no difference in hospital stay, and there was no difference in function or independent walking. The difference was that there was a 92% accuracy in the of coronal tibiofibular alignment. That is the dogma. And so, whereas it was only 68% in conventional. But there is a caveat here. The caveat is the 3 degrees of ideal. That is the caveat. When you confine yourself to 3 degrees, 68% in conventional, 92% in the computer assessment. And now comes the punchline that if you read the paper, very famous paper, please read it, by Jeffrey et al. It says that functionally, if you are within 3 degrees of the ideal, there is no clinical difference. There is no clinical difference. Only when you exceed the 3 degrees does the patient manifest with some sort of clinical disability. So that's the caveat. So yes, figuratively speaking, you are very well off. But when you actually come to practical, well, doesn't really make a difference. Okay, this is another one. This paper is from Germany. So it's again a comparison of a comparative prospective randomized double-blind study, radiological and CT evaluation, comparing navigated with conventional. 80 patients randomized with cemented cruciate retaining, rotating platform design. That was the LPS, which was very much in vogue in Germany at that point of time. And this was assessed with full-length radiographs and CT scan. There was no difference in rotational alignment of the components. So that's what I was saying, that it doesn't really help you in rotational alignment. But in axial alignment, the number of outliers was significantly lower. But again, with the rider, when you are putting the 3 degree of constraint, then yes, there is a difference. Okay, this is from I think this is from Korea. Yes, this is from Korea. Navigation again, a comparison. Now, this really, in my opinion, is the one place where computer-assisted navigation has a definite benefit over the conventional jigs when there is a significant extra-articular deformity, because that precludes the use of intramedullary alignment, and you will have to then depend on either X-rays or some sort of extramedullary alignment jig. So this is where there is a definite role. So better mechanical alignment was achieved, but there was again no difference in soft tissue balancing. And yes, it was particularly useful in the presence of extraarticular deformity. Now, therefore, computer navigation does not ensure better performance of the joint. This is borne out by literature till today, that there is no article which says that computer navigated joints do better than conventional joints. And there were so many, they said, okay, let it be 10 years, let it be 15 years. It is now more than 15 years, no demonstrable difference. There is no increased longevity due to decreased wear. Smaller incision, no, it doesn't really give you a smaller incision. In fact, if you use the pins inside the incision, then you have to give a longer incision, particularly on the femoral side. It gives some data feedback to the surgeon, but it is then how you interpret it. It really doesn't tell you what to do. And there is no decreased revision rate. Revision rate is exactly the same. And these are all borne out by very well established papers. What are the drawbacks? There is a learning curve that is acceptable. Fine, no problems. Requires patience and perseverance, of course. You need that with your wife also. So benefits are subtle, not immediately apparent, and are based on statistical evidence and is mostly numerical. It is not really something which strikes you in the eye. There is increased surgical time, which is generally accepted, but I have no problems with that. Pin trap complication is a definite issue. You can get osteomyelitis and you can even get fractures. I've had a problem particularly in a small framed female. There was a supracondylar fracture where the pins had gone in, and I had used 2 pins. So I think Santosh is doing a good thing by using a single pin navigation. I think that's a better, that's an improvement. So pin trap complications can happen. Now I come to another, I think all of us know Fabio Catani. We have met him many times, especially in the Ranawat ROCs, the Ranawat conferences. So this is a very, very important paper. And he says that you might navigate, you might do anything, very accurate cuts, but still you will not get proper alignment if you do not pay attention to the basic tenets of knee replacement surgery, which is your soft tissue dissection, soft tissue handling, soft tissue balance, and your cementing, and the cementation has to be accurate. So they cannot be replaced by navigation. So 91 cases, even after accurate bone resection by computer navigation, errors were detected in final implant positioning due to imperfect cementation and impaction techniques, which are as important, I would say they're perhaps more important than the computer navigation process itself. So coming to the basic theory of computer navigation, it is basically an adjunct to mechanical axis alignment. Now, ever since Hollister and Howell and Hollister, once they came out with their theory of kinematic alignment, first of all, why did they come out? Because we all know that about 20% patients of successfully, accurately performed knee replacement surgeries are unhappy with the result. And this is something which has flummoxed everybody. And we really started to look into what's the reason. And that was when Hollister and Howell came out with their paper, that the mechanical alignment, while it has its definite advantages, the advantages are that it is easy to understand and it is easy to replicate and it is less complicated. But it is an oversimplification of the reality. And the reality is that the mechanical alignment on which the whole computer navigation system is based is a static alignment. It is not an alignment in motion, which is the so-called kinematic alignment. And therefore, while it is easy to do, while it is easy to understand, easy to replicate, and it is successful in more than 95% of the cases, but in 80% of the cases, but in 20%, it causes a problem because you are not aligning the knee when it is in motion. So that is why they said the patient satisfaction studies have challenged this mechanical axis problem. The mechanical axis is a static measurement. A perfectly aligned knee by CAS still has a dissatisfaction rate of 20%. The mechanically aligned knee is actually kinematically non-aligned. So the other thing is that even if you have, there is the Morgan study, if you read, there's no difference in survivorship of knees when they are in neutral varus valgus, provided the soft tissues are balanced and this malalignment is less than 3 degrees. So that 3 degrees seems to be a magic figure. So if you have balanced the knee, then this problem will not happen. So today we believe that apart from perfect mechanical alignment, what is more important is how well these soft tissues have been balanced and how well you have actually fixed the knees. And we will see in the subsequent papers that it is a large percentage of failures are because of loss of fixation. So I will show you some examples of cases which I have done without computer navigation. I do both, but these are without computer navigation with very successful mechanical alignment. And I disagree with my worthy opponent, Santosh, when he says that in severely deformed knees, computer is better. I would say no. The computer is better in the subtly malaligned knees. That's where you cannot really make out with your eyesight whether you're perfect or not, and that's where the computer helps. In a grossly malaligned knee, first of all, you can easily make out whether you've corrected it or not. Secondly, you don't need that levels of perfect mechanical alignment. What you rather need is to fill up bone defects to get a proper fixation of the components and a proper soft tissue balance. So this is how it was aligned purely by jigs. This is another case, severe varus, again aligned quite perfectly with mechanical jigs. And this is the opposite deformity, the severe valgus, again aligned very well. It needed constraint because of the attenuated medial structures. This is again a rheumatoid, severely unstable knee, which is again needed constraint, but again no computers in these. So with that, I rest my case, and thank you very much for the opportunity.
Well, BD, that was wonderful. And coming from a person who has gone both the ways, it's been extremely enlightening. I'm sure there are a lot of questions to be asked on this, but as they all agreed, we will reserve that for later. Yeah. And meanwhile, I think the next step forward would be go on to robotics.
So I'll stop sharing my screen.
Yeah, stop sharing your screen. That's good. And then the robotics thing, for the thing, Rakesh Rajput is straining at the leash.
Thank you, Indrajit. I hope I'm visible and audible.
Yeah, you are.
Yeah. So I think BD mentioned some very critical points, because we all took up navigation, and in fact, me, BD, and Dr. PK Banerjee were almost simultaneously picking up this navigation, though we had different systems. I think he had the Dipui Brain Lab, and I had CAR2 striker navigation system. So the trouble was that at that time, a lot of things we didn't understand, and we were fighting innovation on one hand, our own understanding of the use of these technologies on one hand, and also the lack of the technicians to actually help us out. I can assure you that in every good, and I think if you ask Thadi, they probably have a permanent computer guy placed in their OTs. You require a technician also with all this, and I think this is the way forward. I mean, there is absolutely no doubt about that. So let me just deliver a quote by Hamilton Bailey, which was about 100 years ago. So from being the first to accept a new technique and the last two of an old one, dear God, deliver us. And I think it doesn't has not waned away. It is still as true as what it was said about 100 years ago. You've all heard Santosh and BD talking about CAS. There is absolutely no doubt that the coronal alignment is very well done by CAS. The problem with the rotational alignment we find is because when we dial in the figures given to the computer, we do a lot of points, which itself are not very predictable. And also when Santosh said that, he would trust computer to the end, I actually don't do that, because, sometimes when you have taken error margins and given a bit of bad information to computer, when you're about to do the operation, you find that there is something not right about this. And you probably don't know that. So if I'm actually in a conflict with a CAS, I actually go back and trust myself more than the computer. And I put my hands up and I said, maybe my registration with the computer was not right. It was what we call as a gigo. So I put in some garbage and I'm going to get some garbage out. So I don't think we should trust computers blindly. I'm sorry, Santosh, I have to disagree there. But, it is something which majority of the time, if you agree and the computer agrees, that patient is definitely got the alignment you were aiming at. I heard PD saying that we probably need to aim at some other axis. Maybe the mechanical axis is not the right thing to do, and I agree with it. Maybe in a lot of patients, and particularly with our Indians who are slightly varus, even in a young age, perhaps the mechanical axis is actually pushing them into valgus, basically, from what they have been. So we need to probably aim at southern axis. Question is, how do we do that with the current conventional jigs we have? So that's the question. So if you are agreeing and you are disagreeing, conventional is not the way to go forward, then how to go forward? So I think here is where, you can debate about CAS and all that. So there are certain drawbacks of CAS. I agree with that. We've all done, and even I was one of them. Once I lost the CAS when I came to a different hospital, I couldn't convince the people to actually go because I wasn't convinced myself. But when the robots actually hit Indian market, and we've got a very major expert of robots sitting with us, I heard a lot of robotic talks, and I knew that this is the way definitely to go forward. I'm not saying this is the only way to go forward, but this is definitely a way to go forward, because what CAS was lacking, robot is also going to fulfill all those which were deficient with CAS. So it not only gives you information. Now the question is, the information which you are feeding to this computer is no more your own error-based you are actually mapping the whole femur out. And I'll probably show you some of these examples. The other thing is you are always in control. You never lose control. Regarding the pin system itself, I agree that one pin, if you're doing a CAS, may be good. But when you're doing a robot, what we have learned is you need to use thinner pins. You need to use 2 pins because one may get loose and you don't penetrate the other cortex. So that way you will never have a fracture. So, and most of the fractures you saw probably were on the femoral side, exactly at the supracondylar, because that is where the junction of the less strong bone with the most stronger bone. So that is where I think you should have been not penetrating the second cortex. That's something we've learned. There have been other things also. It's not just this. PSI came and I really adapted to PSI well. I was very happy with it, though many papers came out. The question was PSI was never going to be popular. The reason was, first of all, it was costing, upwards of 40,000 rupees, which in Indian currency is a huge amount of money. Number two, there was a waiting period of 2 months, nothing less, 2 months. That's a huge waiting period and sometimes I have heard it after 3 months. I don't even know whether the whole alignment, everything has changed since I've actually sent the whole data to them. So that is why I think we were struggling to actually adapt ourselves to PSI. Next, what came was the handheld devices. So when you have a CAS, it's a huge inventory and a huge gamut. So the hospitals were not ready to pay, but now you had handheld, devices available. And so for some patients, like BD said, if you have a extra-articular deformity, I would also say, what if you had implants also there? Let's say you have a supracondylar DCS, which has been put in for supracondylar fracture, and you want to do TKR. Now here you can't put the medullary rod inside. This is where this handheld one, where you just want to do the distal cut of the femur with alignment. These handheld devices are really good. Of course, again, they have a fair amount of cost too. So I think where the alignment and everything we were talking about, robot has come in and it is actually giving you a more accurate assessment of your thing. And I'll show you some of the cases. Now, we are here debating only about knees so far. What about hips? Are hips going to be having a stepmotherly treatment? If you actually even probably Thadi might come out, I have seen hips being done with robots, and probably it may actually become the treatment of choice where hips are concerned. If you take the way the hips are being thing, you will actually have a whole morphology in front of you. You would know what cup angle you are putting in. You would even know how much inward penetration you have gone, whether you have gone towards the teardrop, even you placed your cup high. So I think in hip, actually, it may become the go-to tool actually as days pass by and we get better and better. We are already very good with hips. I think where knees are concerned, the trouble is, I think we have not got ourselves very minded yet. What is the way to go forward in alignment itself? Is it an anatomical axis? Is it mechanical axis? Is it kinematic axis? Or is it some other axis? We don't even know. And that is why what we have seen is whatever knee replacement designs have come in, right from the, let's say from the AJC knees way back in, late 70s and 80s to whatever we have currently, whether you call it Persona, you call it Attune or Triathlon, we've not seen difference in actually clinical perspective. So the design itself, whatever needs we are going to get, is not improving that much what we would like. So probably it's the alignment which still we don't understand very well, and perhaps the design itself we have not understood very well. And now once we understand that well, I think once we get that, robots will probably kick in and give you that much being more effective. So even in knees, I think it's going to be very good once we understand the whole philosophy of knee and look at a different angle. So I'm very happy with BD pointing out with Dr. Howell's paper, but we don't even know whether that he's right or not. We don't know. He's actually set a cat amongst the pigeons. So here is a small screen which I'm going to show you. I'll just try see if my cursor is there. So what you do when you actually plan is you get a diagram of like this. You will even have your implants based in on the right, which I think I probably, can you all see the right side of the screen here?
Yes.
So I'll try and see if I can move this. No. So what is telling you here is the company's name, the actual implant you have put in. This is the implant which has been mapped on this femur. It will tell you how much cuts you are taking distally. It will also tell how much cut you are going to do on the actual tibia. Now just look at the planning here. Now here, when you say gap, it means this is loose. When you have overlap, which means tight. Sorry. So what is telling you here between 30 degrees to let's say just about 60 that you have very loose inflection. Now these sort of informations I can tell you, you're not going to never going to get with your visual eye, and even CAS is not going to tell you very clearly about this. This will actually tell you exactly the range in which you are loose. Now if you want to tighten this, you can do this because you have robot which will allow you virtually. So now if I reduce the tibial cut, and if you see the marker, the lowest baseline is about 3 mm. So I can easily raise my tibial base plate by 3 mm, and you will see all this gradually getting tightening up. I may still have some tightness at around just past 30 degrees, and I can do something more to reduce my slope or increase my slope, something like that. I can play around where I'm actually very good within 2 mm range. You cannot do this with any other technology except robots, and you can actually play around. And it's after this you can do about something else. So this is where I think I'm quite happy for you all to come and actually see. But this is where I think the beauty of a robot, you're actually virtually doing your operation before you do. The other beauty is whatever implants you see now based on the femur and on tibia, I can assure you when you actually finish your operation, whatever casual you may be with your cementing techniques, as BD pointed out, you will replicate exactly this figure in your post-op x-rays, which doesn't happen with CAS. So now you will actually replicate exactly what you're seeing on the screen here in the post-op x-ray. That is what beauty. I will never see an x-ray where my tibial base plate suddenly is touching the anterior cortex or looks a bit more slopey piston. It will be exactly where I'm ending up here on my planning. The other good thing about this is it tells me exactly how much bone to cut once I have planned. So you see this pink markers, it means that I am 4 mm off. Below that, you might see just about the shade blue markers, which is 3 mm, the green markers, which is about 1 mm, and then you have the white markers, which will be exactly where you cut. So gradually you can go and cut. Here you can just see the burr which is coming in. It will burr for the actual jig for you to go in. So if you want to not to do all burr and just do distal cut with burr, because burring is quite compromising on the hand. So that is where I think we can improve with our instruments. So you can put your cutting jigs out here, and then you can go around and do the cuts. Even while you're cutting with the conventional jig, you can still put what we call as a DAW, which is a digital angel wing, and see whether you are still in alignment with where you want to be, where you started. So it doesn't mean that you have to burr everything. So here is again a mapping. You have an implant planning and you have post-op assessment, and you can actually see what you had planned, you are actually replicating. And I should have brought in the screen where even the gap assessment, you will now see it is within 1 millimeter all throughout the range of movement. So this is the whole beauty of robot, which I think the CAS is not giving us. The question is, you have achieved what you wanted to be, but do you know what you want to achieve? And this is the question we are all asking ourselves. Do I know what I'm trying to achieve? So, and once I have achieved what I wanted to, is the patient actually being benefited? We've all heard, even the CAS is giving you better alignment than conventional. Robots are giving you even more assessment, even with soft tissues, which CAS was not giving us. The question is, are patients really benefited? So benefit will come from two ways. One, longevity of implant, and number two, the functions in from patient's perspective. So patient-related outcome measures are, I think, the primary and the most important. And if the patient outcome measures last where we want it to last. So we want to take the implants from 15 years to 20, 25, 30 years. That's what we are aiming at. We know that the implants will last 30 years in a mechanical environment. Are we going to make it last in a patient environment? So here's the thing. I think the first part of this is a huge study, taking nearly everything. And I have this paper. If anybody wants, I can send it to them. It's from Shatrov and David Parker. So they have literally gone around taking huge amount of extracts wherever they could find. And if you look at all the studies, what they have said is there is absolutely no doubt the alignments are increased. Now we will talk about whether the patient-related outcome measures are increased. Where UK are concerned, I think everybody had a reluctant even to think about this operation. Since robots have come in, people have gone with hammer and tong doing actually UKRs. So how come suddenly with the operation which people were not even sure about works or not, why are they suddenly going in with robots? And the answer is they were reluctant to do because it is not an easy operation to do. So when you were doing conventional way, you were getting some things wrong. But the moment you have computer, you know the size of the implants, the alignment of the implants, you know how much cuts to take. So suddenly this operation, which was getting a stepmotherly treatment, has become almost the go-to operation for the first choice when people have stated robots. And there is no doubt there is a huge difference in UKR between a conventional and a robotic treatment. So the reliability and positioning definitely has increased. Let's talk about the patient-specific outcomes. Now, here's the huge sets of papers I have taken away, and we are discussing PROMs, the patient-related outcome measures. And you can see that even with robotics, the PROMs are slightly better. So I can show you a number of papers. I'm sure you will come across showing me some papers saying there is no difference. And I would probably appreciate that in some people's hand, the outcome measures have not been different. I would challenge you to bring one paper which had showed the conventional is better than robot. So, I may not convince you to go for robot, but I can convince you this will be the way forward, because there is a stop at conventional. You are not getting better with, at some stage, you need to look at something else, whether robot will be your answer, whether CAS or something else, which will come in future, maybe your answer, but you got to keep looking at technology. And I think that is what I'm trying to say. The prompts also in majority of papers. So if you probably see here between, 19 studies, you see majority of the studies, even in this case, showed that the prompts had increased. So I can actually go on and, saying that, many papers, but you will show me papers where it hasn't increased, but you will not be able to show a paper where conventional has proven better than robotic. So I think we should not close our eyes to robotic assisted surgery. We should probably, look forward to it. And some of us should try. I'm sure in some people's hand, probably I would look at the younger people who are there, because it is a technology which is difficult to master. I'm sure the younger guys will do even better than the guys who are like us or our age group, because technology, and you see just your mobile phone, the way you handle and way the kids are handling your mobile phones is very, very different. They are so good with technology, and once they get hold of the computers, I think they will supersede with the results compared to us. So I think I'll probably stop here. I won't talk anymore because I've spoken enough about this. There are plenty of papers I can keep on talking about. But in summary, I think before I sign off and I let Vikas argue against it, I would say that one request and one plea: do not fight technology. I would rather say embrace it, because if you don't, somebody else is going to do it. There is a definite benefits of CAS and robotics. Whether that benefit is good enough in your hands or not is a question. If you take cost into considerations, currently as we stand, where we stand in India, I think the robots will lose out to some extent, because cost benefit ratio with the robot is not as much as with the CAS. But I think with widespread use of robots, I'm sure in India market, even the companies will realize that is the reduction in the cost of robots, which will actually sell more, and they will sell their implants also more once they have more robotic technology coming in. So once that comes in, I'm sure many of my colleagues will actually go. At this moment, I agree that it's a bit prohibitively expensive. There is no doubt in my mind, and probably in most of your minds also, that the future is going to be driven by technology. And what I want to sign off again today is that day is not too far. So you embrace it now, or you're going to be otherwise left far behind. So this is our own mascot for our robot, and we call it actually Raka. So thank you all for listening very patiently. I'll sign off and wait for Vikas to hear.
Well, we've had 3 excellent lectures, very thought-provoking ones. So thank you, all of you. But we wait for the president of the West Bengal Arthroplasty Society now to bring us back to earth. Right, Vikas?
Unmute.
Can you hear me now?
Yeah, go ahead. Loud and clear.
Yeah, Vikas, audible.
This is a favorite building of my senior moderator, my beloved Indrada. And can anybody guess which building is this?
Well, everyone
New
can.
Parliament, I think, is it?
New Parliament.
Yes. So we have an enlightened panel here. And I just ask the questions which my moderator would ask. What is the justification? The justification being said about this huge set of expenditure is beauty, is pride, is history, its legacy. But the questions which all of us put today is the need, the cost effectivity, the rationale, and is there no other judiciously better way to address the same issue? And that is what we are actually debating today. And beyond this, what we debate today is that, is this the only way forward? I think it is slightly tight situation in which we are all in with this word only, but I think a debate needs to have a point of view, and that's where we are. So once we go, and my favorite things always, economics, lateral issues, it's not always that technology is a conundrum of a lot of things, and technology is a very misleading, even the art of money management is a technology. The art of taking healthcare to people is a technology. And what you see here in the graph is how the government-sponsored scheme, group businesses, insurances and individual business insurances have actually grown and then settled down and then have degrown in financial year 2019. So the impact of these situations in Indian healthcare, we are looking at our perspective of 130 crore bhaiyon aur behnon type equations here, and we look at it in very pragmatic way of what we are going to address when a technology vis-a-vis the way forward is concerned in Indian economy of healthcare. So we come to navigation. It has been very nicely addressed. Navigation, as Santosh beautifully said, navigation in cars for people who don't know their way, and navigation in surgery, what shall I say, for people who don't know what. Eventually, you use navigation, it is a wrong comparison altogether. You don't navigate cars just because you can't compare apple and oranges. And I think Rakesh has been extremely, and Dr. Chatterjee, B D Chatterjee also has been very, very kind of. So I would let Santosh go on this one. And again, the other two esteemed speakers have again crossed Santosh on 0 degrees is not needed, and that has been a proven entity, varus valgus of 3 degrees. This debate I have felt regarding navigation and robotics is not really about all the techniques. And both the speakers, my learned speakers, my friends Rakesh and Santosh, have shown how they are using the technique. It is about the philosophy. It is about what we are going to achieve and at what cost and where is it going to take us, and whether we have something better which we are going to offer the patient and at what, in which way. And computer, all systems, what I feel today, are making us a slave. And I will come back to this again, how they are making us a slave. Basically, it is a very, very directed agenda in which we are walking as surgeons. So we have seen all these photographs. So the advantages of navigation, basically, although have been discussed, I will bring out these disadvantages here. And these are slides from my learned senior, Dr. Ashok Rajgopal. I have freely used some of his slides, and I have been hugely impressed by what he has said a couple of weeks back. So, and although intraoperative navigation alignment showed no outliers, post-op radiograph, as just now, which has been mentioned, showed 20% outlier, which Dr. Chatterjee very nicely said. And rotational malalignment, come on, we are not looking at patella in both these situations. This is the biggest issue which is going through joint replacements today. The patellofemoral pain is the biggest problem. And if we are not addressing that, are we playing with a very expensive toy? What are we doing? And actually, the computer-assisted patients are coming back with a lot of issues, tight knees, difficult patellofemoral trackings, etc., etc. So I'm not sure why it is not moving. Right. So the current day consensus which has been there is, in the hands of developers of this technology of navigation, there is a 38% conversion to conventional options. So, and it doesn't help in guiding rotation, which is the key to successful arthroplasty. At the best, it has underlined as a high cost, low output option, but a great marketing tool. So as Dr. Rajput just said, the smaller devices, which is like Persona Eye Assist, or the one which I have used in past. I have used the previous CAS versions of standalone for 2-3 years, and I disposed it. That was the Striker system, which I used in 2010-11. And now I use, if at all I need an extra articular alignment, something like this, which is also marketed by Smith & Nephew. And it has shown that it does improve accuracy, but about by 20%, reduce complication by about 10-20%, surgeon focus in the field, very minimal, disposables, well, they are huge, and it doesn't really make a difference. And these are some beautiful pictures of these devices. But of course, they do offer me one very big advantage. I don't have to invest 1 crore to just get a navigation in my operating room. So any patient who needs navigation, and I know that they are not going to help me out with a rotational alignment anyway, I would use something which is intraoperative, maybe spend 50,000 rupees, which anyway would cost patient extra money while doing navigation, and then get away. So my inventory cost is reduced. And this is, I think, the way forward for the navigation technology. So we do have a way forward for navigation technology in such situation as this, where you have optimized your shelf valuation of the things which you keep in your operating room. And that's the way forward. A robot, this is what it is. It is a machine resembling a human being. And it should be able to replicate certain human movements and functions automatically. Automatically is an important word. It's not a haptoid thing which we are looking at. As very clearly said, and I have been party to a lot of negotiations on and discussions and a lot of what do you call technology understanding of these Navio, and of course I have seen a bit of Mako also, although I'm not an expert like our learned friend who's joined us from Trivandrum. So again, the literature reviews have shown, and these are from very big time users of robots. Subtle improvements were seen in robotic cohorts in quality of life measurements compared to the conventional group. Robotic assisted UKA had high survivorship at a very short term follow-up. And I will go into very detailed papers which I have taken out of the Bible of journals of arthroplasty. And these are very, very new papers. In fact, a couple of papers are just in print. And these are really talking some things about robot which we must look at this point of time. One of the papers, which did 48,000 patient kind of meta-analysis with the overview of randomized controlled trial, concluded, this is all from Journal of Arthroplasty within last 3 years. It concluded that for vast majority of patients, a standard conventional total knee arthroplasty with a surgical approach familiar to the surgeon using standard well-established component with or without tourniquet, without surgical drains, leads to satisfactory clinical outcomes. So this is the standard long-term meta-analysis which we have got from a lot of paper. It's kind of a very recent, within a couple of last 2-3 years, which we are getting out of Journal of Arthroplasty. From these three big guys, Bob Booth, Shaki, and Javed Parvizi. Now look at, I hope my friends don't mind the language in which they have concluded. And the conclusion is the promise of robot remains seductive and should be pursued. And these are exact words. One cannot ignore the subjective aspects of unsophisticated patient demand, as we are all aware, marketing allure, and possible psychological patient satisfaction. And I'm sorry to use this word, but it's not mine, it's theirs. The Dumbo feather effect for the inexperienced surgeon. And they have concluded after, and this is 2019 arthroplasty, bringing a robot to your operating room may be much like bringing an electronic medical record to your clinic. All right. Next, another Journal of Arthroplasty, AAHKS Symposium, Robotics in Orthopaedics, A Brave New World. And they said, finally, robotic tools may assist in repetitive learning and training of the next generation of surgeon. Very well said, Dr. Rakesh Rajput. I agree. The robot provides excellent feedback at the time of the use and can follow outcomes and change techniques over time. The ability to accurately record data, blah, 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 all these things. Is it justified over the amount of money which is being spent on these robots? And that too, making us, again, I come back to that slave analogy, slave to one particular implant. So suppose tomorrow, if my patient comes and asks me that I need a J&J mobile bearing knee, and I want to do it with robot, what do I do with a Navio or a Mako? I don't have an answer. So therefore, it is very restrictive as a technology. I absolutely, after having a lot of head-to-head discussions on this, realize that this technology is going to have no ROI at all when we look at the way, and I'll come to that again after some time. Does the use of intraoperative technology yield superior patient outcomes following TKR? This is a 2020 August paper. Now, as Dr. Rajput wanted something for conventional TKR, they have argued it gives shorter operative times. It gives similar PROMS, which he was discussing just now. Why will they talk about better PROMS? Of course, robotics will give you similar PROMS, but they will not give you better. What is better? Better is something which robot has to prove. Conventionals don't have to prove better, because conventionals have already standardized themselves. And anything which has to come in technology has to give a far more outlier better patient related outcomes, outlier wise. They have to be 30, 40, 50% better. Only then the justification of cost comes. Otherwise, if you have a 3 or 4% difference in PROMS, then what is the point of doing a robotic when you know the short-term outcomes are not going to be different, and long-term outcomes one may not be alive to know. You never know, even with conventional TKRs. And I will come to a case which has been shared to me with our senior surgeon from Delhi also. And he has a very nice wording on that. Technology may aid some surgeon, but no short-term outcome. And this, mind you, is a retrospective study. So pros and cons. Now, this is the balanced view of robotics. This is March 2018. Look at the last 5 lines. In era of value-driven healthcare, we are being evaluated by patients, payers, hospitals, government. This is so true for our country. Look at where America is talking about us, similar things which we should be thinking. And government regulatory bodies based on not only the optimization of results and avoidance of complications, but also the cost of care we provide. In the end, it may turn out that robotics may be more beneficial for some procedures than others. For instance, it may have greater impact for UKA than TK. But again, these 2 lines are not for my learned friends, particularly for novice and lower volume surgeons who may have difficulty in achieving adequate precision and balance with conventional. Very hurting lines indeed. And the review article, this is an article which you must read, an impact of author financial conflict of interest on robotic assisted joint replacement surgery. It is accepted today in October only for publication. It is as new as this. And look at the end. They took 54 studies meeting inclusion criteria. And nearly all studies comparing robotic THA, TK, and UK to conventional techniques involve financially conflicted authors. So therefore, if you have a robot or you invested in a robot and you start showing a result, that doesn't make sense. It has to be a justified study which is done with RCTs. So further studies without conflict of interest may actually give you an unbiased result. We are not even there. We don't even have a sample which we are discussing whether it's a way forward or not. It's not even sure of its position at this point of time. Robotic guided, this is completely conflicting to what we just heard in the previous talk. We conclude that the purported advantages of robotic UKA are obviated in the hands of surgeons with extensive training and experience in UKA. Our minimal clinical and radiological differences lend to the argument that it is difficult to justify the routine use of expensive robotic techniques for standard UKA surgery, especially in a well-trained and high-volume surgeon, which my learned friends are, I'm sure. Again, there was a huge meta-analysis, or you can sort of consensus paper in 2018 in arthroplasty, which saw so many things and saw one question on robotic also. The question was, does the use of recently introduced technologies, blah, 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 influence the incidence of surgical site infections? And the delegate vote was, it agrees that it actually influences, it may lead to longer operating times and definitely a higher infection. So the telling comment by Bob Booth was, current survivorship for TK is 98% at 10 years, 95% at 20. Current technology must better this figure, indeed is a high bar. Promise of robotics is to reduce outliers, entirely possible, but alignment and decision making is paramount. Finally, the literature reports do not support superior clinical benefit over navigated knees at 15 years. So therefore, if they are not getting any benefit over navigated knees, and we have already said that navigated knees are actually not as important unless we have an extra-articular bad deformity. Therefore, we are looking at robotics as a 4 times more expenditure than a navigated knee, sitting in our operating room, and we being pushed by the companies to keep doing their surgeries at all point of time, as the present scenario is. So what are the technological trends which are happening? So we are looking at things which are going to happen in future, augmented, and I thank Dr. Rajgopal again for these slides. Augmented reality, technology where a computer generated image is superimposed on top of a visual field. Virtual reality, where, and look, these are the actual way forward when we are looking at, people are discussing this. Why? Because every time we are using a technology, whether it is CAS or whether it is robotic, we are getting enslaved by the purported usage of their implants only. So therefore, it's a very win-win situation. And why I'm coming to the hip. In the hip, as discussed in the previous paper by Dr. Rajput, the hip thing, they are very reluctant to go at the hip. They are still, my software is developing, it is not really there. It will come, we will give you free of cost, bundled with this software also, we'll give you arthroscopy also. All this has happened in my life. Now the issue is that this hip software, they are suspicious that it will give the surgeon a benefit of implanting some other company's hip, because it is actually only going to show you the inclination. And it might be not as restrictive. I have a suspicion on this, pardon my suspicion, but it may be not as restrictive as the knee. So therefore, the control can be in the hands of surgeon in future. And that's why probably it is delayed in their development. So they are trying to make a situation where they'll make an implant which will be probably aligned to the robot. So a new implant might be developed by the same company, which will say that only this implant will go into this particular system, which again is very restrictive. It is not the way forward. Newer materials, we all have used this, oxynium, clinical studies, etc. This is the way forward. We know we need to, when can I get this mic off? Somebody has the mic on and there is a sound at the back. So the oxynium is or I'm not naming oxynium, it's just one of those things. There are other way forwards, I think, which we believe can actually increase the life cycle, hopefully in 15, 40, 30, 40 years, whatever we want. Because I don't think that anybody is implanting a joint at the age of 25 or 30, which is a very big outlier indeed. So if somebody is putting in a joint at 50, they are actually looking at 30-year survivorship already at 80 years. I think that's quite all right. Now, 3D printing is the new kid on the block. Sorry, this slide has been corrupted a little bit. It provides, and these are the advantages and disadvantages, whatever. So I think this is one way where we might have something in our own, and it has been used for the PSI and all kinds of situations. But there is a way forward which people are looking into, bioprinting and making specific implants for specific people, which may have some logic in future. This is again, I shared one of my slides with Dr. Rajgopal, and he in a lecture shared this slide. And this was, of course, 31 years is not what I have spent doing joint replacement yet. So he very kindly, when I saw his lecture, I took these slides. Why do I say this? The case in question. Look at this. He operated 31 years back, and no loosening or osteolysis was seen. So and most of these surgeons like Bob Booth or whoever we have had the chance to learn our surgery, Dr. Chatterjee, who has learned it with Dr. Ranawat, etc., they always say one thing, which we all believe in very big time: follow techniques, not technology. So what did they do right? They followed the basic tenets of a surgical procedure. They balanced the gaps, restored the alignment, got the secure fixation. Only technology used was surgeon's hand, brain, and sound surgical principles. Well, any one of these, if they are not there with our friends who use these technologies, the technology is a dud, because if you don't have these things sorted out, the technology won't really help you out. And the result was a 30-year knee, which was done with a knee which was Freeman. I remember this implant I have used in past, FS knee, Freeman Samuelson knee, which was not a knee which had a separate, you have a left for left and right for right. It was a universal knee. So amazing. You can just cut PCL and still do the same knee. My present position is this present position at this point of time. I believe in CR option. do not resurface the patella. Prefer sometimes, well, I don't have it, but ideally a monoblock tibia, which I don't use at this point of time, but it should be there. I think there is a distinct advantage. I believe that long-term outcomes and survivorship is surgeon and technique dependent. Technology is an aid and one should use it judiciously rather than be a slave to this technology. Only way forward, well, you know my answer, what computer can do. Well, I end here with a philosophy. What are we here for? As friends, as surgeons, are we here? We are here to start a race together. We are running together in this. Are we in a sprint mode where we will finish off as early as possible? Or are we in a business where we want to run a long distance marathon, and that to run, making sure that all of us are on the same boat, same board, etc., etc. Eventually, we all need to finish together in the finishing line. And once that is done, or we are going to be alone in a race where we are only running and nobody else is there with us, and we don't want anybody there with us at all. And of course, we run as we are hounded by these animals, which are, as far as I am concerned, corporate houses, companies, people, pressure of patients, etc., and then land up in a rat race where we are actually being pursued and pushed to use some technology where we are absolutely not convinced that it is the right way forward for our life, our system, our sort of this thing. The only way forward I see for robotics and CAS or whatever we have as technology is the non-restrictive use of these technologies. By doing non-restrictive use of these technologies, only when one navigated system A can tell me the rotational alignment also. So I get both sorted out. That would be the technology of future. Any technology which will give me a chance to use any implant of my choice. That would be the technology of the future. It may come in the guise of being a robot. It may come in the guise of being a CAS. It may come in the guise of being a 3D printed model. But it has to be a technology which has to be cost effective, which has to be non-restrictive, which has to take away all these restrictions which we are faced with. 4.5 crores. Are we talking sense? And that too is not paid by 70% of the people who are under insurance. You keep begging them for money and you keep talking to them about convincing them to get their joint replaced by this because somebody has invested 4.5 crores. That is not the way technology is supposed to work. Technology is supposed to make our life easier, our mind at peace, and make sure that we give consistent results come what may. Thank you very much.
Well, debate. Now, I've been a great believer in debates right from my school days, years ago, and I still believe in it. And today we've had a high quality debate. People have talked about the experiences, their thinkings, their attitudes, the way to go forward. And we've had about 4 different kinds of opinions, all on the conventional plus the other topics. And I, for one has been extremely enriched. The final enrichment will come from Mohan. But today, now, I think we can ask our questions to all the persons concerned in all this. Santosh, many of your things have been questioned by Dr. Chatterjee along his speech. And is there any specific points, BD, that you would like to raise to Santosh at this particular time?
Yeah, actually, hello, can you hear me? Am I muted?
Yes.
Yeah, okay. I think there's a bit of confusion. He said that, kinematically we can align the knee. Now, I'm sorry, that is not true because the navigation does not give you kinematic alignment unless you have a specific software. That specific software, the whole idea is to recreate the pre-morbid knee. It recreates the knee minus all the osteophytes and everything, and then it sort of it makes a PSI, it makes a patient specific jig through which you have to cut in order to get a kinematically aligned femur. Now the tibia and kinematic alignment is very simple. All you need to do is you have to just gap balance it against this femur. That's the principle of kinematic alignment. And with all currently available, commonly available CAS technology, this is not available. So I just want to know if, am I right, or is there something new which has come in the market?
Santosh, your thing on the mechanical alignment and the kinematic alignment and how that can be achieved by CAS?
No, I actually didn't talk specifically about kinematic alignment as such, but what I meant to say is that while we are using the mechanical instrumentation, we are taking anatomical landmarks, we are taking anatomical axis. But once we are using CAS, we are taking the anatomic center of rotation of hip, anatomic center of rotation of knee, plus we take the kinematic center of rotation of the knee. We move the knee in flexion extension, internal rotation, external rotation, and the computer automatically takes the kinematic center of rotation of the knee joint. Similarly, in hip, we move the hip in circumduction in round circle, and the computer automatically takes the kinematic center of rotation. And once we are cutting the distal femoral cut or the proximal tibial cut, we are cutting with the center of rotation of the hip and knee, which has been taken both anatomically as well as kinematically, and we are making it at 0 degree to the 0 degree to the mechanical axis rather than going to any of the anatomical axis. For example, if we are doing a manual system, we are never sure what we are never very sure until unless we take very accurate long leg films. We are never sure how much valgus angle we are supposed to take to cut the distal femur. But here it is always 0 degree to the mechanical axis, and this center of rotations, center of the joint centers have been taken both anatomically as well as kinematically.
Yes, but the argument was that whether this CAS gives you the sagittal alignment or the coronal alignment or the other alignments, it doesn't. So therefore, you are taking it in one plane. And remembering that this is a non-weight bearing positioning.
No, my experience here has been that it tends to push all the knees into valgus. And while it may be all right in, I would say, maybe 95% of the cases, but some people, people who have been habituated to walking in varus all their life, if you push them into valgus, then somehow the patient satisfaction becomes a casualty. So the X-ray looks wonderful, but I'm not sure whether it really. The main argument against CAS, you see, like I said, there are specific instances where CAS is a boon. I mean, if you have a severe extraarticular deformity, or as Dr. Vikash said, that there are screws and nails and all inside, you cannot pass an alignment device, then yes. But you doing it for, and of course, I fully agree with Santosh when he says that it's I think beneficial in a bilateral, because the post-operative recovery seems to be far better. But routine use in every case, and especially whether that is the way forward, well, I'm not so sure actually.
Well, I believe, although I have a limitation that I work in 3-4 centers, 2-3 centers, so I cannot carry the computer to every center. But if I were working at one center, and if I am a navigator, that means I am a navigator. I cannot be navigator once and a non-navigator other way. And as Dr. Vikash told that if you do not know the way we use the navigation in our cars, it's wrong. Actually, if I drive my car to my home, I always use the navigation, because that always shows the shortest route, because that's a real time navigation. It's not our car navigation shows where else where you can get jams, where you can get bad traffic, and it always shows you dynamically and real time wise. It shows the shortest route. So if I am a navigator, I am fully a navigator. And I strongly believe that computer is always right until unless we give wrong data, that is garbage in and garbage out. And if something gross happens, then maybe our rigid bodies have gone wrong. It has rotated, loosened, something like that has happened. And but over the time, as we try to navigate, we realize that we are wrong and computer is always right. This is my belief. Until unless something gross like rigid bodies, something has gone wrong.
I think Vikas has a question here. Vikas.
You're on mute.
Yeah. So, Santosh, navigation, forget about car was an analogy which I had given you, and I am 100% sure driving in Calcutta, you don't need navigation. You are a very experienced driver. And we have all driven lakhs of miles before we could afford a driver. Therefore, I am sure that analogy doesn't hold, it falls flat. The only issue is that today, after having invested in a standalone navigation, you've answered your question. You go to 4 centers and you can't carry navigation everywhere.
Yeah.
So you are restricted by posting that case which needs navigation in a particular center, may it be cost effective or not, you are restricted by the technology, by economics of technology. So therefore, navigation has evolved in a way where you have an intra-op and navigation device, where you are not investing any money upfront, and you are buying it off the shelf, asking the patient to pay for it, and whatever mechanical TikTok you want to do with that, you have done it, and you've got your navigation done, and that's it. And that is what I have always implied about technology. The way forward is of any technology is for it to be sustainable economically and easily acceptable everywhere. That is not the present CAS which we are discussing. That is not the way robotics which we know as of today. And this is not certainly got the way forward in it. It has to change.
Okay, I think we can go on to the discussions after Mohan says he's been a guest and waiting patiently. So Mohan, could you come in now and
yeah, sure.
get talking on the CAS, on the robotics?
Yeah, can you hear me?
Yes, yes, go ahead.
And can you see my screen?
Yes, it's okay.
Yeah, so at the outset, I must thank you all for inviting me to this, exclusive club. I am quite excited to hear all the speakers, and actually they've made my talk much easier because they've touched on a lot of things which I may not touch. So thanks especially to Rajiv Chatter, I call him Chatter, out of love, and Arnab and all of you. My talk today is robotics in orthopedics, an Indian perspective, so it's more my perspective, I would say. So this is Amrita Institute of Medical Sciences. I work here as a clinical professor, and I hope you come here if you haven't already sometime. It all started with Amrita having an advanced center for robotic surgery. So it's got Da Vinci for several years, which is used by urologists, gastrosurgeons, the gynecologists, and all that. And then it acquired ROSA for the neurosurgeons, the CyberKnife for oncology. And so it was but natural that it was going to increase its portfolio with a robot for the joint replacement surgeon. So the Mako was the first in India to come into Amrita, and what we are doing really is Mako robotic arm assisted arthroplasty. So in 2017 we got the total hip and partial knee platforms, and the software for the knee, a total knee, came about a year later. And that is the inspiration for the name, because the company is located in Florida, where this particular species of shark is very popular. So the Mako system, as you probably already know, is made up of a robotic arm, which is the crux of the whole system here. It's got a camera stand, and there's a guidance console. The versatile thing about this system is that you can attach a reamer, a stabular reamer, during a hip replacement. You can, to the arm, you can attach a burr during unicompartmental or partial knees, and you can attach a saw when you're doing the total knee. So the robotic arm is quite versatile in that sense. And of course, we have to go through all this certification before we use it. And I'm happy to say we have done over 300 joint replacements successfully. And this is the first question everyone asks me, what is the cost? And you may not believe it, but Amrita Institute has not really increased the price, probably because it's the first and they want to keep it like that for some time. I don't know how long, but the cost is almost similar to a routine joint replacement. And what we have noticed is definitely the patient walks earlier, stays lesser time, and we are certainly excited to use this technology. So I'll start off with the unis because I'll discuss all three techniques. And basically, I think proper patient selection is the key. Or one should look out for unicompartmental disease. I mean, tricompartmental disease, is staring at you. Basically, you don't have to look out for that. But for unicompartmental, you have to be on the lookout. It could be patellofemoral, it could be lateral or medial. And then you should ask yourself, is it bad enough to need replacing? And is the patient convinced for surgery? Because many patients are not very happy when you suggest a replacement to them. The other thing in the clinics is that it should be correctable. The varus or the vargas deformity that is there should be passively correctable, and that is very crucial. If it's not correctable, then you're looking at a total knee. And of course, you have to explain that a scan is a must for all these robotic procedures. I don't sell robotics, but certainly there are some patients who come asking for it or who are very well informed, and they get excited when you mention robotics. So that's an added benefit. Criteria for patient selection, most of you already know, a decent range of movement, 10 to 90, no recurvatum. The age range is what I find very exciting. From 40 to 80 years, you can do total, you can do partial knees. The Oxford group said the obesity is not a contraindication, but I don't generally do partial knees if the BMI is more than 40. If it's in the 30s, I would still consider it. Osteoporosis is not a contraindication. The ACL has to be stable. I mean, you can't have a grossly unstable knee and try to do a uni in that. 10-degree varus is acceptable. 10-degree valgus is also acceptable, and I'll go a little bit into that later on. And like I said, it should be correctable. There should not be global pain. Patient usually points to one side of the knee, and if a patellofemoral, somewhere is acceptable. So in my practice, I do long leg films for all patients, for all kinds of knees. We routinely do in our hospital long leg standing films, and of course lateral skyline. The other thing I do is also a Rosenberg view, which is a 45-degree flexion view, PA view, and that generally puts more stress on the compartment which is involved, especially useful in when you're suspecting unicompartmental disease. So what is different? So CT scan for all cases, which you would not normally do for routine cases. And like someone mentioned, this is a new equipment. There's an extra equipment which comes into the OT. And we have an MPS or a makeup product specialist, as Rakesh said. He has been constantly there, and he does all the cases. He helps us in planning out the cases. The other good thing is you don't need too many assistants. And these days, I think that is useful. So a single assistant, or sometimes I do the things alone, because you don't really need too many people to assist you. The important thing is to go over the pre-plan, which is there for every case, 10 to 15 minutes before you start off. Then there are arrays and checkpoints as you do in navigation. And I find personally that bone registration is the most crucial process, crucial step in this process. It's like garbage in, garbage out. So if you don't get your registration properly, it will not give you the proper information in return. And the other good thing I find is you can gap balance and adjust your final position even before you take the bone cuts, which I think is a major advantage. I mean, not just the computer planning out your cuts, but intra-op, even before you actually take the bone cuts, you can gap balance it and you can still adjust your implant position at that point. And a bone resection is done with very little soft tissue retraction, which again I find very interesting about this. So we use 2 pins. Someone mentioned not a single pin, not a thing, thick single pin, but 2 thin double pins. And then you attach the arrays. There are also some checkpoints. You have to register the hip center, the malleoli, then you have checkpoints on the femur tibia while you're cutting them. And another nice piece of equipment is this foot holder, which allows you to do away with an assistant. You can move this up and down by yourself, and you can rotate the limb inwards or externally and flex it to whichever angle you want, which I think is very nice about this system. So there you are, a shot of me doing a knee replacement all by myself, and the nurse is just sucking away the fluid. So you don't really need a lot of people around you. So this system is image-based in that you need a CT scan. You have to do a lower limb CT, 0.5 to 1 mm slices. The images are used to recreate a 3D image of the patient's knee, which is very cool. And it is specific for every patient. So it's not a stock picture, but every knee is different. You get all the bony anatomy, and it prepares you to anticipate cysts and osteophytes in all the bony locations. And the surgeon can size the implant perfectly. I mean, I have never got the implant size wrong. If you decide on the plan, it's always there. The optimal position, again, you can decide on that and the alignment. And you can, like I said, you can fine tune it once you open the knee. You can do your ligament balancing, tracking, and fine tune it. So this is the screenshot of partial knee. So you have the transverse coronal and sagittal images of the femur and the tibia separately, and you can see here how you can place the implant wherever you want. You can move it this way, that way, and you can shape match the implant perfectly. You make sure that your joint line is restored and you're not encroaching onto the ACL insertion. You take the implant which matches, which covers the compartment adequately, and also the tibial slope can be adjusted. So again, pretty much the same thing. And the other thing is you can cartilage map it. So even before you resect the bone, you can make sure that your implant is not going to be proud, and it's going to be within the surface of the cartilage. You can check out all this. And another cool thing is you have the centralized tracking, which these dots will tell you whether your implant is reasonably centered. And there is something called a top-down view, which gives you a dynamic view of how your implant is going to move once you move it in flexion and extension. And if you feel that the implants are not tracking adequately, again, you can make the changes in their position till you're happy. And again, tibial screen there. And just a case here, a lady presented with a painful knee, and I happened to notice that her ankle was swollen, it had a scar, and she said there was a plate there. So the story is she apparently broke her ankle, got it plated about 2 years ago, and the knee injury that time was missed. It was probably some kind of valgus, injury, valgus stress. And so the right knee became very painful, arthritic, and so we ended up doing a lateral uni in her. That was incidentally my first lateral uni. So another case here, again, patient comes with HTO done 10 years ago with metalwork. And I initially said I could take out the metalwork and do a partial for him, but I struggled with the metalwork, and it was so deeply embedded, and I didn't want to put 2 incisions, and finally we ended up taking out the screws and just putting the uni there. Another case, and as you get more familiar with the system, you get a bit rash also. And this patient had correctable varus of 15 degrees on the right and 23 degrees on the left. So the left was not a problem. I knew I would do a total knee there. I thought I could get away with doing a uni on the right side, which had 50 degrees of correctable varus. But then the CT scan showed cysts, and then we had to change our plan. So ended up doing total knee. So the lesson here is, if the deformity is more than 12 degrees, so not just 10, but I can push it up to 12 degrees. But if it's more than that, I think we should go for a total knee with the system. But having said that, I did a lateral uni in this patient, and was very amused to find that it measured 20 degrees. So I don't know, maybe it's you can push the limits in valgus knees, but a good correction there without, the other good thing about these things is I do all my knees, be it varus, valgus, deformities, with usual, single midline medial parapatellar approach. And it's extremely easy with a robot, without needing much soft tissue retraction to get your angles right. So my uni journey actually began 2005, 15 years ago, when I did this course in Oxford. But I would say until robotics came, I didn't realize the possibilities. And I would say there are so many things which I have done, for the first time after using robotics, including the patellofemoral, bicompartmental, of course, medial lateral unis. So we have brought out a paper which said our positioning with robotic unis is much better compared to conventional. And we looked at a couple of angles, whereas valgus position of the tibial component, the posterior tibial slope, and basically the accuracy in robotic was much higher. The skin incision, I keep it my usual size. I haven't actually made it smaller, but I have tried smaller incisions, but I found that I cannot get a good view of the entire knee. But I think that is very much possible. I mean, also going to use a smaller incision. I like to look at the entire knee in its entirety, and I prefer the usual big size. But the good thing is I use the GelP retractor. That's all the retractors I need. I don't need a double at the back. It is enough to give you a good view. The cutting burr is very cute, and it's a 6 mm burr, which is rotates at 80,000 RPM, and there's irrigation attached. And I just wanted to show this picture of how precise the burring can be in a medial. For example, it has barely touched the ACL. It's so precise, and it's a marvel, and it's so nice that the feeling when you can put in joint exactly the way you want it. So another patellar plan that you can see. And the best thing is it replicates the computer plan exactly. As what you planned, that's what you get. And here is a lady who you can clearly see is struggling. So she had a lot of starting trouble for several years. And the same lady here, amazingly, she's actually my mother-in-law. And this happened just after the first uni I did in her. She's 75 with medial compartment disease. And happy to say she actually wanted the other knee also doing, which will be a year later. So again, coming back, this is an interesting thing about robotics. Robot may not injure a human being. I mean, that's just a fancy quote I picked up. What I wanted to show is that there's something called haptics or stereotactic feedback that you get, and this is how the screen looks when you're taking a cut. And these boundaries, as you can see, the virtual boundaries, the saw comes to a standstill the moment you go beyond it. And so you feel very safe with this haptic window. So that is quite unique when you're doing the saw. And touch wood, I can say we haven't cut any ligaments so far. So this is the knee plan, which Rakesh has already spoken about. So you can titrate your cuts, you can adjust your position, whatever the deformity, whatever the fixed, whatever the flexion deformity or varus or valgus, you can do the gap balancing, and ultimately you get a very balanced knee. And I'll not go into the details too much there, just to show some of the knees that we did. An extra-articular deformity, not a very dramatic one, but satisfied customer there. Again, as we have done more knees, we have tried to do more deformities and been a bit more brazen about taking on bigger deformities. I think the maximum I have gone is up to 25 or up to 35 degrees of varus. But I must say this particular case is probably my worst, with 45 degrees valgus, which I didn't even think about trying robotic. I just did a hinge knee there. And the other one is also a different system. And I agree with Buddhadev that when you have very gross deformities, you don't really want to struggle, calculating angles and things like that. You can do a very good job, the conventional technique. So, and finally, I'll come to something on the hip. Very versatile 3D planning again here. I think that is one of the highlights of this particular system, is that it comes with a default inclination of 40 degrees and version of 20 degrees. But you can very well move, you can move the cup any way you want. You can reduce the inclination or the version. You can make sure that there is enough bone, you can medialize it. You can make sure that there's not too much of an overhang. And the same thing with the stem as well. You can go as far as deciding the level of neck cut and the version of the femoral stem. And you also get a picture in 3D mode and an X-ray mode even before you have actually touched the patient. So in that sense, it's very, very versatile. And some of the views that you can see here, how well you can plan your cup position. And this is the reaming view that you get. So the green is what you need to ream. And the reaming is also very, gives you a very active feedback, in that as you ream the green and it disappears and the green turns into white, you know that you have reached the reaming. And by the end of it, the whole thing is white, and you know that you have reamed it adequately. Same thing with cup impaction. When you're impacting the cup, you attach the cup to the robotic arm, and it will lock in the position you have planned. For example, you bring it close to the socket, and you position it, and if you wanted 40-20, for example, 40 inclination and 20 version, you can actually lock that position and it will not change. And after that, it's just a question of impacting it and keep on banging it, and it will show you how much distance you're still proud. For example, in this picture, it says 15 mm you're proud. And as you keep banging in, it goes inside. You can see the angle has not changed. The planned angle has stayed at 40-20, and you have reached the bottom, of the socket. So in that sense, it's again very versatile. So just a couple of cases here. 28-year-old Nigerian came all the way with a bilateral OA. One side was avian, very, very painful on the left side, and he was shot by 12 millimeters or 1.2 centimeters. And we managed to plan it and put it in, and he went back 2 mm longer on that side, which can be equalized when he has the other hip done. This is a 41-year-old bilateral avian core decompression done in the past. Incidentally, the right side I did when robotics was not there. So you can see that screw where you always like to always play it safe. You put the screw when you're not very sure about everything. And here on the left side, we have done the robotic, and the fit was so perfect that I was confident I don't need a screw there. And we have increased the range of patients. So here is a 26-year-old with SLE and nephritis, steroid-induced avian on the right side, and we gave her a perfect hip. And then again, once you get more familiar with the system, we have tackled LLDs of 3.2 centimeters in this patient with probably old Perthes, secondary OA hip in a 70-year-old male. And then this lady with row 3 kind of hip OA with a 4.5 centimeter LLD, we have done proper hip and robotic hip and got it perfectly aligned. So a paper which says the robotic assisted hips are much more in the Callanan safe zone, and the conventional ones, you can see there are a lot of outliers. A good paper by Seth Jerabic from hospital for special surgery, I think, where Buddhadev was also trained there, HSS in New York. And he has said that robotic hip replacement gives excellent accuracy and precision with regard to position, offset, hip length, etc. And that's Seth. We had an interview with him and spent some time with him. And another interesting thing is during this journey of robotics, had the good fortune of meeting several robotic surgeons. The other person you can see in the picture is Jay Tilak, whom Rakesh knows well. Both of us are doing the arthroplasties in Amrita, and these are some of the surgeons we met. And finally, thank you for listening me out.
Thank you, Thadi. That was a great talk, getting us to a great journey through your varied experiences and your excellent results. I like the way you brought it up right from the beginning when you were first in, and then gradually the development that started. That was an excellent.
Thanks, Indrajit. Yeah, thanks for the nice words. Yeah.
So we now have a little time for some questions. So anybody else wants to come into the questions? I think Santosh has been questioned quite a lot.
Indrajit, I just want to make a comment on regarding T Mohan's talk. So
Yeah.
yeah, great talk. Yeah, thank you. So I've used this Mako just once, and I think the best part of that equipment is the acetabular reaming. It's done within minutes, and you don't have to rack your brain that am I
BD, you're supposed to talk against it.
Yeah, but that's I'm supposed to talk against the principles, but I think that,
okay.
but as far as that is concerned,
yeah, the reaming is wonderful. You just go with the same size reamer. In fact, what you plan, you just go with one reamer.
Yeah,
bang
one
in.
reamer, and you don't have to rack your brains about whether it is 30 or 35 or 40 and all that in your anti-version. And the greatest use is when you're doing these difficult DDH cases, because the problem there is, how deep do you go in? And this gives it, it's done in minutes. In 2-3 minutes, it's done and it's perfect. So I think the one place where I think the robotic has a definite benefit is the acetabular reaming.
Well, that's why I said. I mean, you may doubt about knees, but I think in hips it's going to be a game changer.
The knees are a bit messy with Mako because you keep on burying it. I think there's some companies which are coming out with saws. I think that may be a better option with the knee. But if you keep burying it, especially if uni is okay, but if you do a TKR with burying, it's very messy.
I also personally agree with you, BD. I think for burying for UKR actually is a beneficial benefit. Whereas for TKR, it just gives you a lot of handshakes and probably some of us might get carpal tunnel.
It's very messy also. Yeah.
Yeah.
So I do a mixture of it. I just do the distal cut with bar and then go with saw.
Yeah.
I think, yeah, go ahead.
Can I ask one question to Dr. Thadi?
Go ahead.
So regarding the hip, I don't know because I don't have first-hand experience. What about putting the screws? Does the robot tell you that put one more screw or 2 screws, or does it say? Because in one of your X-rays, you showed that on one side there was no screw and the other side there was screw. Was it your decision or the robot's decision?
One side was without robot.
I think the one side I put the screw we didn't have a robot that time. So that was done several years ago. And
okay, fine.
Yeah, so at that time I used to use screws. Nowadays, I'm happy if I'm happy with the cup stability, I don't use screws. But again, what a lot of surgeons say is if you're putting screws for any reason, one screw is really no use.
Yeah,
you should have at least 2 screws.
You have to have 2 screws.
Yeah, so most of these are pacifying screws. They just want to pacify yourself.
So what we have felt is when you ream, you always have a little bit of shake, and that gives you an imperfect reaming. Whereas with the robot which you're using, it gives you the robot holds the reamer for you, and basically you then put on the connection and you just put it on. So there is no shake. So you actually get such good stability that your cup goes bang in and it actually fits in. So there's no
absolutely.
It fits in so good actually with that.
You're right. I mean, Rakesh, about that single ream thing. A lot of people say that. It's more of a company talk, I think, using that single reamer, and a lot of American surgeons also do that because the bone is also very hard. Their bones are much more harder than the Indian bones. And I actually feel safer. I start off with a smaller reamer, but I don't use as many reamers. I use, a couple of sizes smaller, and then I go into the final size. But there's no compulsion to use only a single ream technique.
You can start with smaller,
yeah. You can start out.
What happens with robot is it gives you that center where you have to be. So that's what gives you the confidence that you can go with one reamer bang in because you know where the center is.
Very true, and the best part is it won't let you ream beyond the planned point. So you have no fear of breaching the medial cortex or whatever. I feel very safe somehow. I mean, that is, I would say, my predominant feel.
Yeah, Vikash.
Indrajit, can I speak?
Yes, go ahead. So, because I have one question for everybody later on.
Indrajit, you have very easily got out of the role of moderator because this was supposed to be a debate and I was prepared that way, but unfortunately this has become a discussion.
No,
and
You're not through yet.
Oh, you can start the debate, Vikash. Don't feel let down.
No, Rakesh, I'm putting Indra in a spot. Try to understand.
Okay. he had escaped being moderator.
Indra is having it easy today. You know, that is what I'm seeing. Anyway,
yeah, we can't let him off.
Dr. Thadi, thank you. It was great that you have consented to show us some of
Pleasure is all mine, Vikas.
So my issue is that we are not as lucky as you are. Now, look, when I was talking technology, the way forward, and etc., one question, one clinical question I have is that what would you do when you have a protrusio? Have you tried a hip replacement?
Yes, I have actually. I didn't show an X-ray, but I did a case of protrusio where we just went. See, normally the plan that you do on a 3D CT is for the patient's own sized cup, the original cup. But in case of protrusio and all that, you can always go a size bigger so that you are not really going as far as the medial wall. You don't have to project as a protrusion.
So is robot giving you that one acetabular reamer advantage?
Absolutely. See, you can choose. That's the best part. You can. It's like.
I'm not finished. And a screwless cup advantage in a deficient medial wall situation, and those options of putting in a cage and putting in a there are so many other things which you do as a surgeon when you do a hip. Now, if you are doing a routine hip with a robot and you are reasonably sure of your AVNs and hip replacement surgeries, which all of us do on a routine basis, point taken, your robot gives you 111 and you put it in. But when it comes to a situation where you have migrated head into the pelvis kind of situation, a situation where you have post-tubercular mortar and pestle, very, very thin head and big acetabulum, childhood kind of dysplasia. Now, those are the situations where we are actually looking at robot to help us.
Solutions, yeah.
So what are the kind of nuances you would share with us on this?
Yeah, I mean, my answer is very simple. We haven't tried such complicated
Exactly. So that is where I was coming. Yeah,
yes.
Please carry on.
And I mean, revisions, for example, even in knees, we haven't done any revision knees with the robotic system. We have so far whatever we have done have been primary hips and knees. And I heard an American surgeon and I heard some Chinese surgeons as well who are using these robots in slightly complicated scenarios, like what you said, revision scenarios, complex hips. But we haven't reached that stage yet. I don't know if Jay has done any, but certainly I haven't done any complex.
I don't think.
I mean, the worst I did was in an angst situation where I got my cup perfectly. Recently, I did one guy from Gujarat. He had very two stiff hips, one worse than the other, and he wanted both of them doing. So we managed to give him perfect. Hips both same length, etc. But what I'm saying is, there are some situations I think the robot also will get confused as to what is normal. I don't know. I think there was another thing someone pointed out. What do you do when there is a very stiff spine? Does it take into account the changes that you have to do when there is a
spinopelvic angulation.
Exactly.
Yeah.
So, I mean, you can play around with the inclination version. You can do all that. But so far, the robotic program has not come out with anything. But having said that, this year, two people have bought the Mako robots. One is Guruvar Reddy, as you know, in Hyderabad. And there is Ashish Singh from Patna. And what Ashish was saying is that in the latest version of the Mako, they are actually putting in that software for spinopelvic, adjustment. So, I mean,
They
we
have
have to
put in,
watch
Sadi.
this.
They
See,
have put in
all
that.
said and done, I think this technology is new.
So why are you not getting it?
It is not the answer to everything, but it is certainly exciting.
Why are they not upgrading it in the older systems?
They might do that.
So Vikash, I want to answer a part of your question. So, so far we have a machine and we have a human, but the machine is not really thinking like a human. The machine is being made to think like a human. The human is feeding everything. But I think very soon with next generation, and this is where I think we are going to be within next 4 or 5 years, the artificial intelligence is going to come in, where multiple times the experts are going to feed into these machines, and then the machine will really start thinking, and it will actually then guide you where you are talking about the big hips, where should the center of rotation be, what size of cup should I be using. There I think will be probably the apex where we will be heading towards. You very rightly pointed out, and I think artificial intelligence is going to come in very soon. We already have a very limited part of artificial intelligence already. Like, it will not let you go to the soft tissues. That's what Thadi was saying. So even if you want to damage soft tissue, you will not be able to. Machine stops. So that part is still there. But I think the part where it calculates a lot of things which even you are not imagining, that is where I think we want robots to be in 4 or 5 years.
No, actually, where we want, I agree in part. Where we want robots to be is to calculate what we have already calculated. Here, in difficult scenarios, we are actually calculating a lot more things. And a robot probably is not able to calculate yet there. And that is where we are at this point of time. And first of all, robot has to come to a level where human mind is calculating that much. It has to calculate that much and then correct the errors which human mind makes. And that is where the technology has to go. And that is what artificial intelligence I was trying to imply.
Yeah. So if you look at
my issue with artificial intelligence is the artificial intelligence part has to be a program where it will think beyond what I can perceive. The second part is the rationality of putting in that intelligence to use has to become extremely accessible, cost effective, and user friendly. Now that is where, and that technology may not be just robotics. That technology can be, it can have so many other aspects. It can be virtual reality. It can be a cloud-based database which everybody can access. So it can be it is a technology of future where we are looking at a machine listening to some kind of virtual reality imaging or data which is fed, and it is a conglomerate of all the human data available everywhere. So, and that is where probably we are going. It's not just robotics and assistance with computers.
Because there is a system in artificial intelligence which is machine learning. The more you use it, the more it generates its own systems, its own criteria.
That is what is happening at this point.
Yeah, absolutely true, Indrada. If you look at the computers, which were initially fed to play chess with the experts and make the experts better, they have got so better that no human is able to beat the actual computer in chess. Chess is, the computer is now far superior. So it has learned from all the experts, and now it acts as the biggest expert. So I think soon the robotics will take over. We are just denying and sitting here, but it will take over. But what we need to make sure is it still remains under our control.
Robotics has to be assisted by a lot of technology upgrades, and probably it would not remain just a robot. It would become a humanoid. We would rename
it's humanoid already, Vikas.
So if
it's
humanoid
already,
then it is not a robot, and then robotics are not there. I mean, that's not the way forward.
Okay, let me come to one question which I have for all the panel. The question is this, that we are going into the realm of mixopathy, where a young trainee doctor is going to be confronted with various methods. So at this current moment, when we are going to be confronted with all these various systems, which are probably going to come in use, and the young surgeons will be there to avail of it, what would be the ideal person, ideal patient in which one would employ one of these technologies? Say, BD, I would talk to you on your, let's say, the conventional one. Where would be the ideal patient? You would want to do a conventional one. Then I'll go on to Rakesh and ask him which one would you use, would be ideal patient for a robotic one. And finally, Vikas, which one will you use? Finally, when confronted with a patient, an ideal patient, that I will do this and nothing else.
I think the answer to that is it varies from individual to individual. See, if you are comfortable with mechanical jigs, use mechanical jigs. If you are more well versed with navigation jigs or with the arrays, then you use them. So it's very difficult to, it's like the CRPS story. You can do a CR surgeon will do CR anywhere, and a PS surgeon will do a PS anywhere. So
No,
it's like that.
I'm
If
asking
you,
to you specifically.
yeah, if you ask me,
CAS and neutral, so what would you?
okay. If you ask me, then I used to navigate every patient. There was a time when I used to navigate every patient, but today I am more selective. So I will navigate a bilateral because I'm afraid of broaching the medullary canal of the femur on both sides. I will navigate one with an extraarticular deformity, and I will navigate one which has got hardware which will prevent me from properly using the normal alignment jigs. That apart, I would mostly do the cases by conventional method. And in a patient who's grossly deformed and has, you need to do a lot of secondary procedures such as bone grafting, or use a lot of wedges and augments, or ream and do osteotomies and correction and all that. So I think I personally I'm more comfortable using the conventional techniques. Now, in Germany, for all revisions, they use the navigation. But so far, I mean, it's the way I'm trained. I'm probably more comfortable doing the revision in the conventional way. But that's not to say that you cannot do it in navigation. You can. But I mean, the topic of the debate today is it the way forward? So that I have my reservations that it's perhaps not the way forward. The way forward, in my opinion, one of the major ways forward is pain relief. Make the surgery comfortable, and if you can make it a pain-free surgery, I think that's a huge step forward. So that's what I would say.
Yeah, that's great. But the whole thing over there is this. There are two things. We are talking about a dissatisfied patient.
Yes.
Right?
Yes.
I think there's another entity called the dissatisfied surgeon.
Yeah.
So that's the ones why I'm saying this, because Rakesh, you have a case in which you feel that the robotics would probably not be required. But would you do a conventional one or feel dissatisfied that you have not done a robotic one?
No, Indra, if I have a very simply the question of, in cases, I think it will not take me any further. My conventional techniques are going to be good. And number two, we have learned that the speed of doing a case is very important. So in a very straightforward case, and we're talking about those American cases, then we are not talking about Indian cases. In an American case, a straightforward case, I think I probably would be okay with a conventional, because there, if I spend 20 minutes more on that case, then the slight increased chance of infection actually kicks in and will take away whatever little benefits I've got from it. But, for standard Indian cases, which are deformed, which have got, lots of osteophytes, there, I think the robots will kick in much better. Again, in an extreme case, if we talk about not the ones you are mentioning, again, I agree with VD that I will come back and do a straightforward, because again, I'll exceed the time. Timing to me is very important.
Okay, Vikash, timing is important. And would you really be in a situation where, supposing you have access and sufficiently use of these things, would you still go conventional, or would you still be wanting to do something else? And so, in what cases?
I have, in last so many years of till now, with the present CAS vis-a-vis robotic system, I think I have already clarified my choice in my talk to a large extent. Robotic in present form, with the kind of setups we are working in, except for privileged friends from Trivandrum, where the cost of a robotic surgery is equal to the cost of a normal surgery, God knows how it works out, but I'm sure it does. So the issue here is that I am not convinced that robotic is giving a huge extra favor vis-a-vis computers are concerned. That is one. Now, when I look at their investments and the technology and what they are offering me, because they are not offering me rotational malalignment correction to a large extent in my knees. So I don't really find them in a very big superior situation. And we don't have such big pressure of keeping a small implant inventory. All those things don't exist in our country, thankfully. So robotics, I don't really have a reason. In computer assisted, definitely, if I am not keeping a standing computer in my background with an investment which has been made, I do have a place for the intra-op assist devices, which I have used and with a lot of satisfaction, because they give me exactly what the CAS gives me and almost what the robot gives me. Because if you have reasonably steady hands, you'll keep doing the same things. And my cases are very limited: extraarticular femoral malalignments, extraarticular diaphyseal, proximal metaphysio-diaphyseal, femoral malalignments, malunited fractures are the cases which are very usefully dealt with these intra-op eye assist devices, and some amount of tibial malalignments with multiple segmental malunited fractures, which I think again have a place where we use CAS. Otherwise, with the present gamut of technology which we have in the knees, my experience in hip, in technology is quite theoretical because I am a conventional hip guy. So with my limitations of experience in the knee technology, I think this is where I am at this point of time. And I can assure you, none of the cases will be refused back from my clinic for the lack of technology. Even if I don't buy or invest a single naya paisa on these technologies in my operating room, none of the patients will be refused. And that is what that modulate small device has given me, which is the way forward, I feel, in computer navigation.
Okay. One thing we haven't discussed, any of us, is survival depends on usage. How is the knee going to be used later on? You have a 65-year-old lady who is a housewife and who will stay, and his knees are going to go more. But you have a younger active patient who wants to do something else, say in a different strata of society. That will be different. So the usage part of it is something which has to be really emphasized.
Can I take that?
Yes,
is it a question?
Please,
yeah.
Please.
So I am very, very absolutely in the same track which Indroda you have just said, and all my friends are absolutely, I'm sure, in a different way. They think alike. See what is happening in our country, in our social milieu and mindset. A patient once operated for anything on any part of the body will use that part of body very, very carefully. So I have not seen an aseptic loosening happening in last 18-20 years of joint replacement surgery which we have done. And unless there is a fracture or there is a fall which has led to some kind of osteoporotic loosening or some missed fracture which has later on turned into loosening, 99-95% of our revisions hand to heart is infection or a malalignment which has been the primary problem, or a fracture. So it has not been aseptic loosening. What are we discussing as a debate for this technology? You see, these patients, there are patients, I was compelled to operate 16, 17 years back, 38-year-old rheumatoid knees are still doing fine, have lived their 17, 18 years with those older generation knees. Now, those times, we are growing up into those times now where we will talk about our 25-year follow-ups or 23-year follow-ups. And then what are we going to really give a message to the society? These are the patients who have been primed and conditioned because of their operative experience to use their joint carefully, and they will survive. And your question is absolutely pertinent and it hits the nail to the head. That is my take on this question.
Indra, just one
Yes,
word.
yes,
See, there are no papers which have categorically stated that survivorship is improved by robotics or CAS navigation. Survivorship is still dependent on the fundamental principles of joint replacement surgery. And that is soft tissue balancing, number one, fixation of the implant to the bone, cementing techniques or non-cementer, whatever, proper choice of implants, and then alignment of the implants. So nothing has actually affected the long-term survivorship. Even the papers on robotics, which have claimed survivorship, are all very, very short-term studies, less than certainly less than 5 years. Most of them are 3 years, in fact. So that is still very much on.
We haven't really discussed about Pagnano's paper.
Indra, can I come back to what BD has raised?
Yes, go ahead.
See, the robots per se have not been around to such an extent that we can talk about the survival shape for a long-term basis.
Exactly.
CAS has been around, right? So, but robot for UKR, and even Thadi has given you the paper, and I have got plenty of papers. For UKR, it's already showing a difference even within first 5 years. Because UKR, when it fails within 2-3 years itself if you've done badly. Whereas a TKR, even when badly done, seems to last 8 to 10 years. So I think if you want to look at survivorship between robot in a TKR and conventional, you're going to look beyond 10 years.
Exactly.
And
so
your question,
just
a minute. So where 65 years you mentioned, it's a very specific point. All papers, there are plenty of papers, BD, where 65, even in a CAS, has definitely shown an improvement in survivorship. It has not shown improvement beyond age 65. But age 65 and below, there is a clear-cut distinction from all the meta-analysis that there is an increase in survivorship.
Yes, but we don't have an Indian meta-analysis. I think what we deal with is a 65 here and a 65 in the Western countries.
Well, you got to bring down probably by 5-10 years for an Indian scenario. So let's talk about a 55-year-old in an Indian scenario.
Yeah.
And then the data probably will be very similar.
So that is an issue over there, which I think has to be done about the usage part of it. The last, probably the last question before we wind up, it's already fairly late. We are talking of kinematic alignments. Now, if we are doing that, there is no way of getting a kinematic alignment surety in most of these systems that we have discussed today. So would that mean that we go back to the rotating platform type, which will adjust itself during the walking procedure? Or is that considering the fact of the LCS, etc., whose data we already have? So what does the panel think?
I think I'll let the answer come.
You heard that? I was talking about the kinematic alignment. So you use a rotating platform type of thing.
If nobody wants to take this, I'll take it into that. So if you talk about the kinematic, am I audible into that?
Yeah, cutting it off.
Yeah, I think my internet is a bit weak at the moment. Am I audible now?
Yeah, better. Go ahead.
So where you just spoke about kinematic, there are two ways of doing this, Indra. Is you're looking at axis of tibiofemoral and also the patellofemoral axis, both. You're looking at all these axes together. So you're looking at coronal, axial, and the patellofemoral movement in different planes. So either you do a patient-matched implant, you do all these axes and decide and do a patient-specific instrumentation and implants. So you cut according to that and you already have implants based on that. Your conventional jig is not going to allow you that. Robots do allow you that, Indra, because you can plan both in coronal and sagittal plane the way you want to cut, and you can actually come to 1 degree assessment. If you want 2 degree varus, let's say, you will end up at 2 degree varus because that is the system which is allowing you. Maybe you'll end up with 3 or maybe 1 because of the cementation which BD pointed, but you will end up very close to 2 degrees. With 1 degree either or 95% cases you're going to end up there. So you will end up what you want. The question is, we do not know in knee what we should aim for. That is where we still are. Whether kinematic is good or mechanical axis is good, we haven't answered that question yet. Both the houses are still fighting with that.
Yeah,
but if you, whatever you decide, you can end with computer, with robots there.
No, my question is different. It's different in the sense that we don't usually test this on a weight-bearing position. All the things that we do through the computer, the robots, etc., etc. We take the bony landmarks and we modulate.
That's true of all knee replacements, isn't it?
Yes.
The patient is supine.
So yes,
You know,
so
you're going by that. So
No, we,
that problem should apply to
no, but this problem is
methods of
bigger. We are talking about now. The question is
surgery,
opening
whether
up.
it's robotic or conventional.
The question in
What I want to
the
tell you is, this question was asked to one of the robotic masters, the guys who have been using it right from the beginning, and they said, they don't believe in kinematic alignment here. What they are actually striving for is something called dynamic, because in the robotic, say for the knees, they are never looking at getting it into valgus or making a varus deformity into a 5-degree valgus or whatever. They're just looking at they undercorrecting it. In fact, what they say is they strive to undercorrect it. They don't want to go into anatomical correction of the entire deformity. They want to correct most of the deformity, and if they fall short, also is fine. But most important thing is during the surgery they want to get their ligaments balanced. So they call it a dynamic balancing. So I think with this robotics and CAS, a new kind of balancing has come in, which is like what Rakesh showed. He showed a graph also where he's trying to balance, get all the looseness absolutely equal throughout. So it's more of a dynamic balancing which you're striving at end of the day.
Yeah, the question that I was raising was this, that if we are to get a weight-bearing situation, would a rotating platform be a better option? Because that in road weight-bearing adjusts itself to what pressures are there. We have that mechanism in, and that's borne out by the fact that the LCS knees have survived so long.
Can I talk?
No, in that, shall I take that, the rotating platform?
Yeah.
Yeah, you see, the rotating platform has only one purpose. That is, it decouples the torsional forces from the axial forces. That's all it does. That it does not allow the torsional forces to be transmitted to the bone implant interface.
Which means that survivorship will be more.
Yeah. So theoretically, they said that there is going to be a survivorship, but it has not been borne out by the papers. If you look at all the papers, the survivorship with fixed bearing and rotating platform has been exactly the same, which is why a lot of the proponents of rotating platform are now reverting back to fixed bearing.
A lot of these discussions are happily going towards the point I have always raised in a conventional way. These operations are all inexact operations on human body. We are doing a surgery on a particular joint, forgetting about the gait analysis and kinematics of the core muscles, of the back, of the way people are moving, the way they are lurching, the way their weight-bearing patterns are, the way their foot axis alignment is, the way their ankle alignment is, their hind foot alignment is. We are discussing to the limitations of our knowledge and putting the technology on that particular parameter which we know and we think has given a certain amount of survivorship. So you have actually started a debate on something which I have always believed in tacitly, that whatever you eventually get on table as something which you have balanced well in your hands and is actually something which has survived 95% survivorship, most of them. Number two, your question, Indrada, of rotating platform. Now it does. I have a reasonable amount of work on this in past, and the purpose of giving rotating platform was initially marketed as deep flexion and all kinds of things which RPF and a lot of cut in the posterior condyle used to be done. Those designs were modified. But really, actually what I found, it is a reasonably forgiving option in a patient in a reasonably good surgical hand, where you have a leeway of 2 or 3 degrees of patellofemoral malalignment situation. It can really be a blessing for a surgeon to get away with 3 to 4 degrees of malaligned, your rotating platform is able to give you that level of comfort. So you may have less patellofemoral in the newer design. In the new design, I didn't want to name the company, but CR 150 RP knees are probably with the larger patellar, shallower grooves, with more accommodating patellar groove, with a rotating platform design in a reasonably good experienced hand, which all of us have, would probably be a choice implant if you actually want to put in a rotating platform, which kinematically would give us a more forgivable kind of knee if we are doing it right most of the times. We have been hardened by these monoblock knees and standard knees. So I think all of us here, every person sitting in this panel probably would gain slightly better with a rotating platform of that type.
Right. So I think we have exceeded our time. I think, where is Rajiv? I think he's exhausted 5 cups.
No, he's here. He's here.
5 cups of coffee, I think he's finished.
I just wanted to
he's not happy because we never spoke about cemented hips with robots.
Well, that's a topic for another discussion. I'm sure we are going to have more of it, what with everybody around. And I can say really all my things that I have been immensely benefited by one of the best webinars I have personally attended. I think I must thank the speakers, thank everybody who did this. And all in all, this has been a most enjoyable evening. And not only enjoyable, it has been a great learning experience. So I thank all of you. I thank Vikash, I thank Rajiv, BD, Santosh, Mohan for an excellent thing, Rakesh, with your valuable inputs. I think we've done a great job today. And this is all what the West Bengal Arthroplasty Society is all about.
Yeah, I'd like to add something. We
Yes,
have a very generous sponsor, Blisson Pharma, who have been patiently hearing, and obviously they need a couple of minutes to tell a few words.
Yes.
So invite.
We conclude with their speech. So Blisson, whoever is there, come online, please. Show yourself and give us a couple of minutes on how not to operate. Is anyone there?
Yeah, Tushar is there and Subhendu is there. I see them.
Yeah, good evening.
I can hear you just now.
Tushar has grown a beard, I can see that.
Tushar, not on.
not audible.
Indrajit, if you're there, if you can come in.
Shubhendu.
Sir, am I audible, sir?
Yes.
Audible, yeah.
Hello.
Audible and visible.
Yeah, now
Hello.
you're audible.
Yeah, Tushar is audible.
Hello.
Yeah, carry on.
Yeah,
Carry on.
we can see you. Go ahead.
Sir, good evening to everyone. I hope I'm audible to all of you.
Yes. Go ahead.
Yeah, sir, good evening once again. And first of all, at the outset, congratulations for this very incisive debate, but it's not incisive, it is intellectually incisive, whatever I could understand. It was really great, and congratulations to all the panel members, speaker, moderator, and organizers, everyone. And also, thank you for giving us an opportunity to be a part of it. And sir, actually, can I present to a few slides if I am permitted?
Go ahead.
I will not take much time, sir.
Yes.
Sir, actually, I would like to thanks IOCON was the place where we launched Blisson, and so this is very special to us. And it is not only IOCON; it was IOCON organized by WOA. So there is a very strong connection with Blisson and launch of Blisson here. And sir, to take few moments, Blisson is having a backup of big manufacturing of bulk drugs, intermediates, and formulations. We are partner for more than 50 countries, 200 companies worldwide, and world-class manufacturing facility, advanced formulations. We have the manufacturing, and also we introduce the products through proper clinical research, and we do have the robust product pipeline. and we have amazingly superior products for spreading the happiness of health and joy. Just to share, this is one of the product which was accepted and liked by many orthopedicians across India, because the advantage of Bonio is the only combination which is complete for osteoporosis management. And I will not take much time here. This is the specific thing, pyridoxal 5-phosphate, and it gives 500 milligram elemental calcium, vitamin D3 2000 IU, and plus all the homocysteine lowering agents. So that way it makes a complete solution for osteoporosis management. And Fame Bonio is Bonio plus DHEA, which is superior to isoflavone, which is suitable for all the female patients. And here it comes our arthritis, the Stibgon Pro, which contains 5 ingredients, where natural eggshell membrane, and all these proven ingredients, which gives a lot of benefits. And also Stib1 RS, this is mainly made for those patients who willing to go for vegetarian option, and also the benefit of rosehip extract, Boswellia. And the beauty of this is 50% less than all the competitors which are available. And these are the few products which are liked and accepted by many eminent orthopedicians. And with this, there are many more which my colleagues will be introducing. And thank you once again to all the organizers and for giving this an opportunity. And we assure you that we'll be there for a lot of academic initiatives which will be done by WOA in future also. Thank you, and once again, stay safe during these pandemic times. Thank you, sir.
Dushar, thank you very much. You've been a great supporter, and
Yes, sir.
very comfortable with your presence. So keep it that way, please.
Yes, sir. Sure, sir. Thank you.
Any other is Chinmoy there, wants to conclude, or shall I conclude?
I think we haven't heard anything from WBOA. Is
Partho was there, he's gone off.
Partho here, or
Nobody is there, sir. I think.
so Arnab, on behalf of WBA, you can say, na, you are a
No.
EC member.
Sardar sir will continue.
Okay. Ex-president, yeah.
Okay. So as I said before, we've had a wonderful time, and thanks to the WBAs and WBA for being with us in this, and Plissom. So as I said before, and I have no hesitation repeating it again, this is one of the best webinars I have attended. Great talks, great learning experience. And Rajiv, you and Vikas, more of it, please.
Every month, promise.
Okay. Thank you so much. Thank you, Mohan.
Thank you.
Thank you very